that the aqueous has to go through. So once it gets through the trabecular meshwork, then it finds itself in Schlemm's canal. And then after Schlemm's canal, if the aqueous finds itself in aqueous veins and episcleral veins, which then eventually get drained by the systemic venous system. So this is, again, a human model of the outflow. And it happens that the rat outflow, which is the animal that we study in our lab, is pretty similar to the human, at least at the level of the ultrastructure level of Schlemm's canal. And these are actually castings that were made by Morrison and colleagues of the rat outflow pathway. And again, very similarly, you can see Schlemm's canal here, which is then fed off by aqueous veins and episcleral veins. So again, here's a schematic here. Here's Schlemm's canal here, and here's an aqueous vein there. So again, briefly, here's the Goleman equation. Again, Dr. Stamer went over this, so I won't belabor this point too much. But basically, unlike what Dr. Stamer was pointing out, which is we can try to alter these things in humans and these variables to lower the IOP in humans. If we do the reverse in our animal models and alter these variables in the opposite direction, we can actually raise IOP, right? And so we can alter all of these variables to raise IOP and try to modulate or model glaucoma in our animal models. So which direction do we need to take these? Well, we can either increase the rate of aqueous production, right? So that'll increase your IOP. You can either decrease the facility of outflow in your model. That'll elevate IOP. Or you can increase episcleral venous pressure. That'll also elevate IOP. So we're going to look at all three of these. And in fact, there's been models that have been created that have done all three of these individually to raise the IOP. So let's first focus on increasing the rate of aqueous production. Well, it turns out it's actually pretty challenging to directly increase the rate of aqueous production in vivo. It's not very easy. You would have to do some really, significant systemic changes in your animal model to increase the rate of aqueous production. But you can increase the volume of fluid within the anterior chamber and really just overwhelm the outflow facility, okay? And one way to do this is to cannulate the anterior chamber and connect this cannulation to an external source of fluid. So that leads us to the first model that we're going to talk about, and that's the anterior chamber cannulation models to raise the IOP. There's sort of three major arms or models that we'll look at today. I'm sorry if I don't cover all of these models, but I tried to be as comprehensive as I could in the next about 45 minutes. So the first model we'll look at is the model by Croston and Bowie, and a similar model by Sun and Jacobs, where they actually cannulate the anterior chamber with a glass needle or micropipette, and they connect this connection to a fluid column or a motorized syringe, and they raise the IOP that way. The second model we'll look at is what's called controlled elevation of IOP, or CEI, developed by Morrison and colleagues, and that's using a needle or plastic tubing in the AC, and that's also connected to a fluid column. And then finally, we'll look at Bello and Passaglia's model that was recently published, where they surgically implant a tube that's connected to a bidirectional pump that simultaneously monitors and adjusts IOP in awake animals. So here's that first model that I spoke to you about by Croston and Bowie and colleagues. And this model was specifically developed to induce very low levels of RGC death, okay, to explore RGC recovery after injury in young versus older animals, older mice specifically. They did extensive work to show that 50 millimeters of mercury for 30 minutes in 12-month-old B6 mice, so it's very specific, will kill around 10% of RGCs at 28 days, but also led to a recoverable loss of interretinal function. So how did they do this? Well, they took their mice and they anesthetized them with IP injections. They used a micromanipulator and a pulled glass needle, which they inserted into the anterior chamber through the cornea. This needle was then connected to a tubing, which was then connected to HPSS reservoir. And the IOP was raised by simply raising this reservoir. And the IOP was raised again to 50 millimeters of mercury for 30 minutes in the injured eye. The contralateral or the control eye was cannulated, but the pressure was kept at 12 millimeters of mercury. And a variation of this approach has since been developed where a syringe is filled with HBSS and is mounted on a motorized syringe pump, so it's a little bit more controlled. And what they found in this model is that they selectively affected the inner retinal function using some functional tests here. And they were also able to look at the tissue with immunohistochemistry, and they found that markers of Mueller cells, such as GFAP and HO1, were elevated as early as 1 day post-injury and even sustained up to 7 days post-injury. And they were also able to look at markers of retinal ganglion cells like Thy1, the mRNA expression of that, and they saw that it was downregulated by 7 days post-injury. And finally, they looked at cell death, and they were able to see tunnel staining signifying cell death 1 day after post-injury. They were able to count this, and that was elevated over baseline. But again, it recovered by 7 days, so it was recoverable. And overall, there was no real change in the thicknesses of the layers of the retina. So these are the pros and cons of this model, and this was actually published by the authors, which was really nice of them to do that. The pros are that it's a well-defined, fully recoverable and treatable injury. It's highly reproducible. It's non-ischemic. You have the ability to measure the impact of demographics, so you can have different aged animals in this model, and you can have the ability to easily measure the impact of intervention on retinal ganglion cell recovery. The cons are that it's not truly a disease or glaucoma model per se, and to the credit of the authors of this paper, none of our models really are truly human glaucoma models, right? Human glaucoma happens on the order of decades. It happens very slowly. We're talking about primary open-angle glaucoma, and we're trying to recreate this in animal models that live for months, and we're trying to do this with IOP elevations over a matter of hours. So again, none of our models are exactly like human glaucoma. So that's a limitation of all of these models. It is an invasive technique, although animal trauma is minimal if you're careful with your anterior chamber cannulation. And it does require need for repeat anesthesia. Again, if you want to put the animals under for example, to do ERG studies, you do have to do repeat anesthetics. And we'll talk about why that might be an important variable in certain animal models. So the next paper we'll look at is the paper by Jacobs and colleagues, and they sort of did a similar approach to the Croston and Bowie group. What they did was they used B6 mice, and again, used IP injection. They used a similar glass micropipette to cannulate the anterior chamber. This was connected to a pressure transducer and a saline reservoir. The reservoir was raised, but they raised the IOP only to 30 millimeters of mercury for 1 hour in one eye. And this is sort of what the cannulation looks like. This is when the cannula is in the eye, but the IOP is normal. And then they raise the IOP to 70, just in this particular animal, to show some blanching of the vasculature of the eye to kind of prove that the pressure is going up. They were able to look at inner and outer retinal perfusion at the low levels of IOP elevation, and they saw no significant change over baseline. But if they took that up to the 70 millimeters of mercury, they can certainly cause ischemia. Again, this was just to show a proof of principle that they can get that elevation. But really, the 30 millimeters of mercury is what they were looking at for their injury. And what they were interested in this paper was looking at the astrocyte response. So normal astrocytes labeled here with GFAP, but after 3 days of this short course of IOP elevation, they became much more dense in their process extension. And they were able to study individual astrocytes using this model. This was a different set of animals that express GFP in a mosaic fashion in astrocytes. So they can look at individual astrocytes and look at their processes over time, and they saw that this could change. Interestingly, every time I look at this, It reminds me of my gray hairs. So if you look at a mirror and you've got a gray hair, you can kind of follow it around, and this is kind of what they're doing. They're kind of following these processes around in a sea of, black and darkness. And in this model, they were able to show that there was no significant axon injury at this level of IOP. And they came up with a model where the initial IOP elevation causes retraction of astrocyte processes, and then they sort of normalize over time and reestablish themselves, but maybe they do so at a higher frequency, so you get sort of more of a dense astrocyte structure. So we'll move on to the next model. This was the Morrison model that was recently published, the controlled elevation of IOP. And this one was done in rats, and it's using 6 to 8 month old male brown Norway rats. And these are anesthetized with isoflurane. So it's a gas anesthetic versus the IP injection that the other two models used. And 5% isoflurane is used to induce the anesthesia, and then the rats are maintained on 2% isoflurane with oxygen as the carrier. Waste anesthesia is actively collected and removed, as well as CO2, and that's really important. If you have anesthesia that's building up, you can get a little too much anesthesia on board. The animals can actually reduce their blood pressure and can actually die if that happens. The same thing with CO2. If you have too much CO2 on board and you're not actively pulling that away in these animals, that can affect their physiology. Using a sterile 31 gauge needle, the cornea was cannulated using a self-sealing wound, and this was connected to a saline reservoir, and the saline reservoir was raised to an IOP of 60 millimeters of mercury for 8 hours. So it's a much higher pressure for a much longer duration than the first two models that we saw. During this time, the animals are wrapped in a water bath controlled heating pad so that they stay nice and temperature regulated. They are hydrated every hour with subcutaneous saline. Again, for 8 hours, you want to make sure your animals don't get hypovolemic and drop their blood pressure. And then the IOP was measured every 30 minutes using an external tonal lab tonometer. So not only was the transducer checking the pressure, but we were also checking pressures with a tonal lab. This is what the setup looks like. So the animal, again, is housed here. It's getting inhaled anesthetic gas here. This is the tubing that connects to that needle that's within the anterior chamber there, and that's, again, connected to a reservoir that's raised. And the pressure can be raised quite quickly from sort of baseline at 20 to our 60. And this was measured with both a 23 gauge and a 31 gauge needle in the eye. And again, the response was quite rapid in using both of those. And this is the physiology of the animals over 8 hours. So again, this model made sure to really monitor physiology because, again, over 8 hours, you can potentially get into trouble with loss of blood pressure, loss of oxygenation. And so all of this was looked at, heart rate, blood saturation, respiratory rate, blood pressure, and it stayed very stable during the 8 hours. And when we looked at the effects of this injury, it did cause significant injury that we graded on a scale of 1 to 5, 1 being no injury, 5 being complete total injury, and it caused a significant injury of about a 2 at about 10 days post-injury. And we can see that injury at the level of the optic nerve head with these degenerating axons. And interestingly, when compared to the 50 millimeters of mercury at 8 hours, again, that caused some statistically significant changes over controls, but really it was the 60 millimeters of mercury that caused the most significant injury that we could see. And again, the injury is sort of this focal area of axon degeneration that we can see at the level of the optic nerve head. And finally, we looked at multiple genes that were up and down regulated at different time points after this injury. Really interesting, there's some genes that are upregulated almost immediately, such as the cytokines like IL-6. And then there are some others that take a little bit longer, and they're seen more 3 to 10 days post-injury, like the cell proliferation markers. So what are the pros of this model? Well, it's highly controlled. The IOP is very reducible, and you can choose any IOP range and duration, provided you stay within the range that doesn't cause ischemia, and we'll talk about that. IOP is actively monitored during the experiment by two mechanisms, again, the transducer and the tonometer. You can investigate recovery once IOP is normalized. You can get real-time physiologic monitoring of animals, and again, that's really important with extended systemic anesthesia, as we talked about, particularly when it comes to blood pressure. There was no significant reduction in optic nerve head or retinal perfusion, and that was actually looked at using OCT, and it was published in collaboration with Ricky Wang's group at University of Washington. And what they found is that there was no significant capillary drop-off, in other words, perfusion, up to 60 millimeters of mercury. But as soon as you got past that, then you got significant drop-off of capillaries. So we were sort of right at the cutoff for when you would really induce ischemia. So 60 seems to be the magic number. If you go higher than that, then you risk causing ischemia in your model. And finally, there was limited axon injury, particularly if you're interested in early events in axon or astrocyte injury. This is a great model. The cons are that it requires 8 hours of monitoring animals under anesthesia, right? So you can't leave these animals and go get lunch. You have to monitor them and make sure they're doing okay. In our lab, we take sort of 2 to 3 hour shifts. So we kind of switch in rat sitting during that 8 hours. It does require corneal incision. Again, if you're careful with it, it usually does fine. It self-seals. It doesn't cause any significant corneal edema, but there is a risk for that. And just like it was a pro, this could also be a con. It causes limited axon injury. So if you're interested in really moderate to severe axon injury, this is probably not the model that's going to get you there unless you modify the model to something that you're able to look at. So we use the specific model to look at the astrocytes, and what we found is that after 8 hours of IOP elevation, the astrocyte processes, which are shown here in red, which are really stereotypically arranged in normal eyes, perpendicular to the tubulin axon or the axonal axis, they become quite perturbed. The astrocyte processes change their orientation very rapidly after IOP elevation. And then one day after IOP normalization, they actually revert back to normal orientation. And we were able to quantify this and show that in a large number of animals, there was a statistically significant change in orientation. And what's interesting is that this happens before there's actually some perturbation of the tubulin signal. So the tubulin signal actually goes down as well on day 1 and day 3, however, and that normalizes by day 5. They both normalize at day 5, but the astrocyte changes seem to precede tubulin changes. And by the way, this is all before any noticeable axon injury is noticed. We have to wait till about 10 days before we can notice axon injury in this model. And we looked at other markers of actin dynamics within the nerve head. This one happened to be phosphorylated cortactin, which is important in actin dynamics and integrin dynamics. And there's very little phosphorylated cortactin in controls, but as soon as we elevated the IOP by day 1, the phosphocortactin was elevated. It stayed up on day 3 and then normalized on day 5. All right, and this is the paper by Bello and Passaglia. This is the last paper of the anterior chamber cannulation segment of the talk. And they developed a smart pump to monitor and control intraocular pressure simultaneously. And this is what their apparatus setup looks like. They surgically implanted a cannula within the eye, and this is what it looks like after it's healed. And so that cannula stays in the eye, and they have some really good long-term data for that cannula basically being fairly benign in the eye. And they were able to get really great sort of stepwise increases in their IOP. Their recorded IOP was essentially the same as their applied pressure, and they can keep a pressure relatively steady in this animal over 90 days. So they kept this pressure at 40. Interestingly, in the first month, they saw a lot of noise, and they figured that that was related to the ambient temperature in the room. And so once they figured that out and kept the temperature a little bit more steady, then they actually reduced that noise further. So this is a really interesting model for long-term IOP elevation, or maybe repeat IOP elevation. So you can raise the IOP to X, normalize it, come back and raise the IOP again, so you can look at what the effects of multiple injury might be on the eye. Okay. So back to the Goldman equation, what's the next thing we can alter to raise our IOP? Well, we can reduce the facility of outflow, right? And so how can we do that in our animal models? Well, this is that schematic I showed you earlier, and you see that aqueous kind of flows through and into the trabecular meshwork, as you heard earlier this morning. Well, what we can do is block the entrance into the trabecular meshwork, and we can do that by using microbeads. So microbeads of a certain diameter can actually be injected into the anterior chamber, find their way into the trabecular meshwork, and actually clog the trabecular meshwork. So many labs have looked at this. And in fact, Morgan and Tribble did a really nice review of all of these microbead models in that same issue that Claude was referring to, the 2015 experimental eye research publication. And what you see here is the tremendous variability in these models. So most of these models were done in rodents. The injection volumes were very variable. Some use viscoelastic or Viscoat or Provisc. It's a highly viscous solution that we use in human intraocular surgery. It alone can clog the trabecular meshwork and cause IOP elevation. It's transient. It doesn't last forever, but that alone can cause IOP elevation. The type of beads were mostly polystyrene. Some were fluorescent labeled. Some actually were ferromagnetic, and we'll talk about the advantages of all of those. The bead counts and sizes were quite variable, anywhere from 1,000 beads to 10 million beads, and again, ranging from 1 micron to 10 microns in size. Some of these papers reported IOP max. All of them reported a mean IOP. And most of them looked at damage by one way or another, either retinal ganglion cell count or optic nerve head axon degeneration. One note about the importance of IOP max and mean IOP. I think both of these are really important, and I think both of these should be related and reported in models. You can imagine that you can have two similar models that have the same mean IOP, but if one has a really quick high max IOP and then levels out versus another one that just kind of has a slow, steady increase in IOP, you get the same mean IOP, but that may not be the same exact disease process, particularly if you're having a really high Tmax there. So I think both of these are important to report in any model. So let's look at a couple of these models. So there's the Sappington model that was published in 2010. That group used, again, about 1,000 beads that were quite large, 15 microns. They got a mean IOP of about 20 millimeters of mercury over 2 to 4 weeks after one injection. And then you compare that to the Frankfurt model, where they used a lot more beads, and actually 2 different size beads at higher counts, and they included 3 microliters of Provisc. Interestingly, they got a mean IOP of 15 millimeters of mercury with a larger standard deviation over a 12-week period after a single injection. So again, lots of variability depending on which beads you end up using. And Morgan and Tribble tried to sort of correlate this in their review, and they basically found no correlation between bead volume and what the mean IOP was. The black squares here are rats, and the white diamonds here are mice. And again, they basically saw no real correlation. So here's the paper, the Sappington paper, where they looked at fluorescent microbeads, and this is what they look like in the eye. So you can sort of track them when they're in the eye because they're fluorescent, and they were able to show that they do find their way into the trabecular meshwork or the angle of the eye, and presumably cause their effects there. They also showed that IOP was elevated in all volumes of microbeads that they used. And there did seem to be some relationship with the volume they used and the degree of IOP elevation. And they were able to show that they can cause axon injury in both rats and mice using this model. And this is the Frankfurt paper, and they also saw significant elevation of their IOP with bead injection. And they actually reported another way of reporting IOP, which is this mean cumulative IOP, which is another nice way of reporting total IOP exposure over time. Now, interestingly, in the Morgan review, they also talked about and introduced the ferromagnetic beads. So these can be injected into the eye and then guided using a very thin magnet to the angle. So you can sort of draw these beads into where you think they need to be. The other advantage to this is that it clears the central axis. So if you're interested in looking at OCT findings in the posterior segment or ERG findings, this would be a little bit more preferable than the sort of straight polystyrene beads. And then they also reported the variability in these models. So these are the same exact models in two different animals. One had a really large pressure spike initially, the other one did not, and sort of steadied out during the time of the experiment. So again, what are the variables that affect IOP in this model? Well, the cannulation technique, so the corneal wound construction is important. You want to make sure it's a self-sealing injection site. You don't want to have leaks coming through your injection site. Using the correct gauge needle relative to the bead size. So if your beads are much larger than your needle, most of it's going to get clogged in your needle. It's not going to find its way into the eye. The course or injection time, whether you inject very quickly or slowly over time, there wasn't really enough data to make a conclusive statement on that. And then the carrier, do you use viscoelastic or not? Again, that may affect the rate of IOP elevation. So if you have viscoelastic, your IOP might spike sooner and faster and to a higher degree than if you did not. And so what are the pros and cons of this model? Well, it's a pretty rapid onset of IOP elevation. You don't have to wait too long for the IOP to go up. These are commercially available components, so you can buy these off the shelf. It's relatively easier, in quotation marks, than some other models, i.e. you may need less surgical experience to do this. The cons are, again, the mean and peak IOP elevations can be quite variable, and it's based on bead size and volume and carrier. You need to avoid the introduction of pro-inflammatory or microbial agents in the beads. So if your beads aren't clean and they're not sterile, you might have a reaction in the anterior chamber, whether it's sterile or infectious. Viscoelastic solution could be included, but in addition to causing a pressure spike early on, it may actually alter the stiffness of the rodent cornea, so that when you go and measure the IOP, it could give you a falsely elevated IOP because now the stiffness of the cornea has changed, because you're no longer hitting cornea against aqueous, it's cornea against viscoelastic. And then the majority of microbead models result in some obscuration of visual access, less so with the ferromagnetic beads. All right, so let's move down a little bit downstream from the trabecular meshwork. Let's move on to the Schlemm's canal and episcleral veins. Okay, so again, this is the schematic I showed you earlier, and this is really the level we're talking about here. Can we go a little bit downstream and block either Schlemm's canal or the aqueous veins or the episcleral veins, and again, back up the system and cause IOP elevation? The answer is yes. So there's several ways to do this. You can laser the trabecular meshwork, the Schlemm's canal, and the episcleral veins. You can cauterize episcleral veins. You can ligate episcleral veins or the globe itself, and you can sclerose episcleral veins. So we'll go through these individually. So let's look at lasering either the TM, or Schlemm's canal, or episcleral veins. So this is a paper that was published and looked at translimbal laser photocoagulation of the trabecular meshwork in a rat model. They used a diode laser, which is 532 nanometers. The animals were anesthetized with IP injection, and if the IOP did not go up, they actually repeated the laser on those animals, so they could have gotten two laser treatments if the IOP did not respond the first time. And their setup, they did multiple exposures to laser, and they had sort of three major groups. The first or second group got 360-degree trabecular meshwork laser with the majority of episcleral veins also being lasered. The second group got most of the TM laser, but they left an area untreated. And then the fourth group just had the trabecular meshwork lasered without episcleral vein lasering. And this is sort of how they targeted the trabecular meshwork at this angle with their laser. And this is their power settings for the lasers. And what they found is that almost all of the groups had a significant elevation of IOP, except group 3. And this was the group here where they did a partial trabecular meshwork lasering. So they left sort of a quadrant unlasered. I think the takeaway from this is it's sort of an all or nothing response. If you leave some of the trabecular meshwork untreated, the aqueous humor will find the path of least resistance, kind of find its way out. So you really need to laser 360 degrees of the TM to get an IOP elevation, at least in this model. And again, they were able to show that they can raise IOP either if they did trabecular meshwork alone or in combination with the episcleral veins. So this is a mouse model by Weinreb and colleagues, and it's similar. They were also targeting the trabecular meshwork / limbal vasculature. What they did that was a little bit different here is they actually caused a little bit of anterior chamber shallowing before they lasered. So they actually stuck a needle into the anterior chamber and actually withdrew some fluid from the anterior chamber. So they're trying to show here that the anterior chamber flattens here a little bit, and then over time it recovers. The reason they did that is if they shallowed the anterior chamber, they can get the iris a little bit closer to the cornea, sort of create a little bit more of a physiologic touch. So when they apply their laser, there's a higher risk of scarring. And what they found is that they got a pressure elevation that was sustained for about 6 weeks after this treatment. And they were able to show some scarring here at the level of the TM. So this goes back to Dr. Tam's point about really looking at the trabecular meshwork after this treatment. They were able to look at histologically and see scarring again at the angle within the eye after this treatment. So this is another paper that looked at B6 mice, and they use argon laser. So a little bit different than the previous models where they use diode laser. So this is a green laser, and this is these are their settings here, and they used again 360 degrees of the limbus and any veins that they could see within 1 millimeters of the limbus. And what they saw is that they could get IOP elevation and as well as retinal ganglion cell loss at 2 and 4 weeks. They didn't have any published pictures of their application or their histology. Next, we're going to move on to the another mouse model for ocular hypertension, to induce chronic ocular hypertension. This paper came out of Iowa, and what they did was they actually targeted just the episcleral veins. So here's the limbus here. This is where the episcleral veins would be, and these are the laser spots. They did use a diode laser, but in this particular model, they actually injected indocyanine green into the anterior chamber. So indocyanine green is a dye that we typically use for retinal application, but in this case, they put it in the anterior chamber. Just based on aqueous humor dynamics, it found its way into the episcleral veins, and so the veins would then have this dye within them when they applied their diode laser, so there was a higher chance of energy being taken up by the dye and thus the episcleral veins. And they also were able to show scarring after application of the laser in the episcleral veins. They got IOP elevation that was sustained for at least a couple of months. And they were able to show again that there was some scarring that occurred at the level of the TM, and they had loss of axons and retinal ganglion cells on histology. This is a fairly recent paper that was published this summer. And again, it was a lasering of the episcleral veins, and this was in CD1 mice, both 5 and 8 week old, using a diode laser. And they either got just episcleral vein laser or episcleral vein laser in conjunction with sort of limbal laser, but not complete. They sort of left a piece of TM or limbus untreated. This is the schematic they included in the paper. There was no actual images of animals, and these vessels that are being pointed out are called episcleral veins. You have to be really careful about which vessels you're lasering, and we're going to talk about this in a few slides ahead. But you can confuse episcleral veins with vortex veins, and you can laser them. You can laser both of them or either of them, but they may give you different responses. So you have to be very careful, and we'll talk about what that might look like in an actual animal. In this paper, however, they went ahead and lasered the episcleral veins, and they saw pressure elevation in both the single and combined application in both 5-week and 8-week-old animals. And they were able to show with anterior segment imaging that there was some adhesions formed between the iris and the cornea. So again, the angle looked a little bit more scarred post laser. And again, they were able to show by OCT and live cell imaging that there was some thinning of the retinal layers and loss of retinal ganglion cells. So now let's move on to the next way of decreasing facilitated outflow, and that's to cauterize episcleral veins. So instead of laser, we're going to use heat. Okay, so this is a fairly older paper looking at chronic ocular hypertension with episcleral venous occlusion in rats. And again, this is that schematic that we just saw in the 2017 paper. It looks very similar. And again, this time, these episcleral veins in this schematic are further away from the cornea. They're not touching the limbus. And again, these, to me, look more like vortex veins rather than episcleral veins. Again, I'll show you what it looks like in a rat in our laboratories. But again, you have to be very careful because if you're lasering vortex veins and you think you're lasering episcleral veins, you might just cause global ocular congestion, because now you're cutting off venous drainage not only of the anterior segment but also the choroid and the retina. So again, you have to be very cognizant of that. They were able to show IOP elevation with 1, 2, or 3 main cautery, but again, you can see this huge spike in IOP when they cauterize 3 veins. And again, I would argue that if you're cauterizing vortex veins, that might be the reason why this pressure was so significantly elevated. You're just causing ocular congestion of the entire globe. So here's a mouse model of episcleral vein cautery. And in this one, they actually do show the veins. This is still a schematic, again, of what's called episcleral veins in this paper. But again, I would argue, at least from what I know from rat anatomy, that these may actually be vortex veins. They're really beefy veins. They come out sort of near the equator, and they drain the entire globe. They were able to cauterize those, and they did see an IOP elevation. So you certainly can get IOP elevation with vortex vein cautery, again, due to a congestion. But they got IOP elevation by doing that, and they were able to show that the system was less responsive to excess fluid in the aqueous. So they actually pumped in aqueous fluid at a rate of 0.1 microliters per minute in either control eyes or lasered eyes. And in the control eyes, it was able to recover faster than lasered eyes. So both eyes had trouble recovering completely, but the lasered eyes had more trouble. And they also saw a loss of retinal ganglion cells. So then let's move on to ligating episcleral veins and ligating the globe. So this was a paper that was published by Karen Juice and colleagues. And what they did was they developed a lasso that would go around the eye. And here in the schematic, it shows it going around the limbus, which is probably where you want to put this lasso. You know, if you're further back at the equator, you can occlude the vortex veins, again, as we talked about. And if you're further back, you can actually occlude, the nerve head. And so you don't want to be that far back. You want to be right at the limbus. And they were able to show that with the lasso on, they weren't causing any major ischemia. They raised the IOP for an hour to about 35 to 40 millimeters of mercury, and then they would stop, and then they would repeat. So they did this several times. and they were able to show loss of peripheral and central retinal ganglion cells, as well as loss of axons at the level of the optic nerve head. What's interesting is that they saw a really high variability in their response. So these are individual animals that underwent the same treatment. Some of them had lots of injury, some of them had no injury. So again, there's a lot of variability with this specific model. And this is a paper that was published by Liu and Bui and colleagues looking at chronic ocular hypertension by a circumlimbal suture in rats. And this is a model where they take a suture, a nylon suture, and actually surgically place it around the limbus, just posterior to the limbus itself, and then tighten it to raise the IOP to a certain amount. And in the sham animals, they just sort of put the suture on but didn't tighten it. They actually took really great care to be sure that they're not too far posterior with their sutures so that they're not occluding the vortex veins. And they were able to show nice IOP elevation in the lassoed eyes. And they saw thinning of the inner retina over time. And they saw loss of retinal ganglion cells on immunohistochemistry. So here's the issue of episcleral versus vortex veins in rats. And I'm going to show you data from our lab because this is what we work on. So this is a rat eye. We're just sort of holding the conj with an instrument there. And this is a view of the sort of circumlimbal vasculature there. That's part of the vasculature that Morrison and colleagues made a casting of. And this is an episcleral vein and artery that's sort of feeding this circumlimbal set of vessels. So that's what we're talking about, at least in rats, when we're talking about episcleral vessels. Now, if you go further back, these are vortex veins, right? So they're big and beefy. They look like a Y. They feed into sort of the equator of the eye. They're draining the entire globe. They're draining the choroid. They're draining the retina. So if you cauterize these, and you can, it will raise IOP, but it will also cause retinal congestion, choroidal congestion. So you're going to get a lot of other signals and changes. And if you're specifically looking at retinal changes, these may be significantly different than just raising the IOP alone, okay? So finally, let's look at the episclerosis model. This was another model that was developed by Morrison and colleagues. And what they did was they isolated or identified the episcleral vein, again shown here. This is the limbal vasculature, and this is vein and artery feeding off of those. And using some tools that were developed by Dr. Morrison and his colleagues, they were able to isolate the episcleral vein and cannulate it with a very fine needle. So this does take a lot of surgical experience. And once they cannulated it, they injected the system with hypertonic saline. Hypertonic saline is used to actually collapse vessels in other fields, like in dermatology. And what they're showing here in the publication is the limbal vasculature before injection and after injection of hypertonic saline. You can see that those vessels have blanched. And so you know those vessels got hypertonic saline, and over time they sclerose down and basically are no longer patent. And that's how the pressure is elevated in this model. So it's a chronic elevation. And they were able to show that they can sclerose the episcleral veins. And again, they got really good IOP elevation in some animals not so much. So there was some variability in the response. And again, you can imagine it depends on the anatomy of the animal, how well you cannulated the episcleral vein, et cetera. So it's a little bit more variable than for example, the CEI or controlled elevation of IOP model. So what are all the pros and cons of these outflow obstruction models? Well, with the laser model, it is extraocular, so it's a little bit easier. You don't have to do any intraocular surgery. However, laser is fairly pro-inflammatory. We know this in humans. You laser an eye, and you need to usually put them on steroid eye drops, or else they get very inflamed. It does require a laser, and again, you must take care to avoid the vortex veins if you are just trying to target the episcleral vessels. Very similar pros and cons for cautery. Again, it's extraocular, but it is pro-inflammatory, and you have to avoid targeting the vortex vessels if you're not trying to affect those. The ligation model, that's also extraocular, and the nice thing about that is it's reversible. So that's the model where Liu and Bowie and colleagues put a nylon suture around sort of near the limbus. And it's a more controlled IOP elevation, so the tighter you make it, the higher the IOP goes. There's a question of whether it causes ocular congestion or not. Again, if you're anterior to the vortex veins, it's less likely to do that, so you're not ligating the vortex veins as well. And then finally, the sclerosis model that was described by Morrison and colleagues. Again, it is extraocular. There's very little inflammation that's caused by this because you're not using cautery and laser, but it does require some surgical experience to perform. Good. A couple of last slides here, looking at the effect of systemic anesthesia on IOP. So in humans, most systemic anesthetics lower the IOP. Okay, and that's essentially true for animal models. So almost any anesthetic you give to your animals, it's going to lower the IOP. Morrison and colleagues looked at this really carefully in the rats, and they looked at both isoflurane, the inhaled anesthetic, and ketamine versus ketamine cocktail, which are IP injections. And they found that almost immediately after injection, there was a reduction in IOP. So within 5 minutes, you were at a baseline lower IOP, whether it was inhaled gas or an IP injection of systemic gas. And they did this with standard lighting or constant low level lighting, which actually raises the IOP to a higher baseline. Same result. Within 5 minutes, you had a lower reduction in IOP. So again, that's just something to know if you're looking at using systemic anesthetics. And a paper by Cohen and Quigley looked at this effect in mice. So they looked at CD1 mice, and they repeated IP injections. They didn't see any significant difference between the repeat IP injections. They did see a significant difference between IP versus gas anesthetics. There was a 2-point difference between the two. Interestingly, when they looked at B6 mice, there was a statistically significant difference from one IP injection to the next. So there seemed to be some memory left behind from the initial injection. So again, there's some strain variability and strain-specific changes here. So if you're constantly doing repeat anesthetics in this strain of animals, you have to be cognizant that you may get different IOPs every time. And same with the CD1 mice, they saw a significant difference of about 2 millimeters between the IP injection versus the inhaled anesthetic. And then finally, the effect of animal age on IOP and axon loss. So this was looked at again in the Cohen and Quigley paper, looking at the two different strains. Interestingly, what they saw in the CD1 strain, no significant difference in baseline IOP in 2-month-old versus 10-month-old animals. But when they looked at B6 mice, the 2-month-old animals had a slightly lower IOP than the 8-month-old animals. So that was statistically significant by about 2 millimeters of mercury. So again, something to take into consideration if you're looking at age differences. And then finally, looking at axon loss over time, this was really nicely demonstrated by Superna looking at the rat. And these animals were followed throughout age, and axons were counted manually. And they found that there was a really nice, steady maintenance of axons over time till the animals got really old, between 25 and 30 months of age. And then there was a slight drop off, and they showed that here. So this is important if you're looking at age as a variable. In humans, as Dr. Sitt pointed out, over time we're losing retinal ganglion cells, and we think it's in a linear fashion. That may not be the case for rats. Okay, they may maintain their axon counts for most of their life. So if you're looking at a specific model where you want to look at aged animals and assume that they have less axons, you really have to be sure that they actually have less axons. So in this case of the rats, you have to really wait till they're quite old. Excellent. Well, thanks for your time.
One question. So when you showed the screen around the circumference of the eye and the region, what guarantees that actually increase the intraocular pressure?
Yeah, it could be, absolutely, it could be. Yeah, the question was the model that uses the circumlimbal ligation, where you suture around the eye and sort of pull it tight. You know, what is how do we know for sure that it's not simply just, you know, causing mechanical deformation of the eye and raising the IOP, kind of like pressing on the eyeball? You know, that's probably part of the mechanism as well. So, you know, you have to take that into consideration in addition to obstructing episcleral outflow, potentially.